Hello, and welcome to everyone who is joining us today on this IAFC webinar. This is our 9th Corona's Task Force webinar. We conduct them every Monday at 4 p.m. Eastern Standard Time. I hope you can join us in the future. You can register at iafc.org. My name is Gary Ludwig. I'm honored to serve as the President and Chair of the Board for the International Association of Fire Chiefs. I want to thank everyone who is joining us today on this webinar, either directly or later when you will be listening to the recording. The IAFC represents the leadership of over 1.2 million firefighters and approximately 30,000 fire departments in the United States. We also have members in Canada and all countries around the world. Our Coronavirus Task Force is chaired by Chief John Sinclair, and the Economic Task Force is chaired by Chief Steve Pegram. You'll hear from Chief Sinclair today, as well as others, including Dr. Jim Augustine, who provides us with weekly medical updates in regards to the coronavirus. And you'll also hear from our Legislative Government Affairs Director today, Ken LaSala, on the latest legislative update. We're blessed today to have our Fire Administrator, United States Fire Administrator with us, Keith Bryant. Keith will provide us with information, and he also has two special guests with him from the federal government that he will introduce. And lastly, we'll hear from Chief Pete Lawrence that will speak to the issues around the CARES Act that was passed by the Congress and the terms and conditions of that CARES Act and how it impacts EMS. But before we begin the program, again, I want to give you some numbers that I have in the past, as I traditionally have done in the past. And that includes we have recently done an economic survey of our IFC members and kind of extrapolated that information out and carried it out to its logical conclusion using data analysis, which has a plus or minus 4% accuracy rate. Anyway, these numbers are pretty staggering on the economic impact that we're going to see as a result of the coronavirus. Our projections is that fire departments will see over the next 12 months a loss in tax revenue to support their operations at approximately $16 billion. That's billion with a B. So far, about approximately 1,000 firefighters have either been laid off or have been furloughed. And this number is also staggering. We project, based upon our survey, that approximately 30,000 firefighters will be laid off in the next 12 months. So those are some draconian numbers that we are trying to work with Congress to fund the AFG and the SAFER grants. We need your help. We need you to go and let your voice be heard with your senators and with your congresspeople. The best way to do that is through our Legislative Action Center at ifc.org/takeaction. It's pretty simple. You just fill in your zip code and your address and your name, and pretty much everything is filled out, and you just send it off, and you'll get a reply back from your elected officials in Congress. The other grim number I have to report to you is that last week I told you that we have had 41 fire and our EMS deaths related to COVID-19. Those are accurate numbers. The NFFF, the National Fallen Firefighters Foundation, is tracking that information. That number has jumped to 9 within a week. So we are now at 50. That's 50 deaths that we can attribute to the COVID-19 disease, to firefighters and our EMS personnel. So again, our thoughts and sympathies are with those families and all that they're enduring during this time. So with that said, I am now going to turn it over to our Coronavirus Task Force Chair, Chief John Sinclair, who will be able to provide us with some information. John, you now have the floor.
Thank you, President Ludwig, and thank you to everyone that is on the call and to our guest speakers here coming up. To honor the time with our guest speakers, I'm going to keep this short. The task force continues to work with the administration on issues surrounding supply chain, and that supply chain of everything of the basic needs of masks, gloves, gowns, protective eyewear, but also to testing kits, antigen kits, all of the different things that are looking at the best available science, We are also working with Chief Pegram and Chief Ludwig on representing the IAFC's interest to the elected officials and to the administration officials, making sure that they know our fire service needs. So I just want to give a huge shout out to President Ludwig for his efforts to make sure that the elected officials know what our needs are, and we'll continue to work with the IAFC staff to make sure that our needs are well known. As you know, many states are beginning to ease up on their community lockdowns. We're beginning to see some uptick in the virus because of this. That's predictable. And we'll see there's communities that will see an uptick that will be locked down again. Overall, the trend line's beginning to look good. However, there continues to be some hot spotting, and we're finding hot spotting in some very rural areas. So it is incumbent upon chiefs listening to make sure that you know how to get help intrastate, and if it overwhelms your local EMS system, do you go through the IFC? Do you go through your state? There's different ways to do that. Contact us if you don't know the process, and we'll get you tuned in. So with that, President Ludwig, thank you for your leadership. I know we have some very important news coming out, so I'm going to make my comments short and end them now. Thank you again for the opportunity.
And thank you, Chief Sinclair, for your leadership on the COVID-19 Task Force. You took on that assignment without hesitation or any reservation, and you have done outstanding and yeoman work there. So thank you, John. I appreciate that. Our next guest is Dr. Jim Augustine, and Jim, again, is also a member of our coronavirus task force. And Jim, every week, has new information that, again, updates us, and no doubt, again, he will provide us with very timely and needed information, as this information changes almost daily and weekly and hourly. So, Jim, you now have the floor.
Chief Ludwig, thank you for your leadership. I want to confirm that you can hear me.
Yes, Jim, you're almost a little bit too close to the mic, almost a little bit. So
very good. Okay. My report this week to you all will be about a future look at the coronavirus and our expectations moving into the fall. If you will, we are in the operations phase of this incident, and our focus now needs to be on planning, logistics, and finance. What you as a chief need to be watching for at this point is the development of state and local tracking systems matched with local testing systems that will allow you to continue across the summer managing any potential outbreaks in your community, particularly those in congregate settings, and those which are impacted by our usual summer weather events appropriate to your geography. Some departments are working with their state and local organizations to organize strike teams to help congregate setting sites that are impacted with more seriously ill patients and patients needing hospitalizations and patients dying. So that in particular has been nursing homes and in jails. The fire department typically does not have that function as part of it, but we're moving into very atypical and all hazards time for fire and EMS. What is very important for you to watch locally and in the events that occur around reopening are the hospitalizations and deaths in your state and in your local regions and your EMS volume. Please pay less attention to the number of positive tests that are occurring. As we dramatically improve testing capabilities at the local and state level, you will see the number of positive tests go up. Those do not necessarily indicate that there is more disease in your community or your state. It does indicate that testing capabilities are higher. And with reports to the state, what is really important to watch are hospitalizations and deaths. Next slide. My most requested slide from last week's presentation was this one. On the left side is the number of deaths that occur in a monthly basis in the United States. You will notice, and may match your local sources, that we have a decreasing number of deaths into the summer months. That is because typically winter weather conditions are harder on Americans and we die at a higher rate. Our average across the year is about 7,500 deaths a day. Since the beginning of this year, the CDC has composed the chart on the right. It showed a high number of deaths occurring for the month in January and into February, but then a dramatic decrease in the number of deaths as we both saw a decrease in influenza cases and then dramatically decreased the number of people who are killed in accidents and other typical events this time of the year. Beginning in March, we saw an increase represented by the orange triangle in coronavirus case deaths. And those are going to be picking up and are likely to increase a little bit as we go through the next month. But then we'll have a tendency to trend down over the summer. And our hope is that they don't trend back up over the winter. Next slide. Always what's important is how we are taking care of our members, our staff members. And it's time now for the chiefs to be checking on personnel mental health and the need for breaks and vacations for people who've been working very hard for the last 3 to 4 months. You need to continue to monitor members' health. And we give you the 14-page document, or 14-day document here, not 14 pages, 14-day document here that you can monitor individuals' personal health in regard to symptoms and in regard to their temperature. It's also the time of the year when gowns would ordinarily be coming off and are going to become, frankly, a bigger threat to people as we get into hot weather conditions. So some agencies have moved to a position where, unless it is a higher risk encounter, like intubation, breathing treatments, and other aerosol generating procedures, the gowns will come off for the safety of their personnel and may be placed back on in the back of the ambulance or in other sites where the person can expect to be sneezed on, coughed on by the patient who potentially has the disease. Another question is how long we will be using masks in the station, and that is likely to be a locally determined procedure for you as the incidents within our fire EMS personnel go down. The use of masks in the station may decrease. Next slide, please. Testing is changing in that more options are coming available with a greater volume of tests, and the speediness of the tests are increasing. In the early days of this outbreak, we had many tests that were available but took a very long time to come back, and it greatly delayed your decision making as the chief or as the person overseeing operations. We now are seeing more rapid and point of care tests that are available in minutes to a few hours and allow you to do rapid decision making on the health of your members. Next slide, please. The use of antibody testing and other blood testing is becoming the key to future waves. And as we learn more about the application of IgG and IgM testing, whether that's from a serology specimen or from a finger prick test, it will improve our ability to protect our people and serve our communities. Next slide, please. For the fall, some of our public health leaders are forecasting a fall peak in the incidence of the disease. So that's the big hump on this slide here. And it will be our opportunity to better serve our communities if this should begin to take place by, again, flattening the curve. And flattening the curve will occur with better processes that allow us to put more PPE in place, rapid testing, including both antibody and antigen testing. In many of your communities, there are discussions going on about keeping hospitals as a uniform receiver of patients. With testing available, it may be possible to designate hot and cold hospitals. Cold hospitals are ones where COVID patients will not be welcomed, or if they happen to arrive there, they will be transferred out to a hospital that is receiving and providing care for coronavirus positive patients. You will need to have local discussions in regard to your hospital systems needs to have the routine healthcare system available for patients who arrive on a seasonal basis. So that's our ordinary influenzas, our ordinary winter asthmas, our ordinary winter GI outbreaks that still may occur. What is changing about the spring outbreak is that rapid testing will be available. So patients will be brought into an anti-way area of some type at the hospital. They will be tested to see whether they have a coronavirus positive test. If so, they would move to a hot hospital or a hot area of that hospital. And other patients who have fallen on the ice and broken their hip and are test negative will be taken into the cold area of the hospital and routine care provided. You, as fire chiefs and EMS leaders, will need to be involved in that process in your community. We also expect that by the fall, more PPE will be available for you, but that we need to prepare for that PPE with the good processes in place that will keep our members safe. Next slide. There are a series of recommendations that have come from some of the influential groups, including the Center for Infectious Disease reporting and policies. These are for governmental leaders and are important for fire and EMS leaders because our position in the industry is to give accurate risk communication to government officials, and that will need to occur at the local level as well as the state level. Last slide, please. So a second shutdown is possible, and we know what that would do in impacting our communities and our finances in this country and in other countries. The fall season would clearly be busier because of the mix of coronavirus with influenza and other winter diseases. It will be important for you to lay the baseline now for flu vaccines for both your members and the community. You may be asked, as you were in the H1N1 days in 2009, to be administering flu vaccines to your community to reduce the impact of influenza on our winter volumes. You may be involved in testing out of the hospital, including at places like nursing homes and other hotspots in your community. Does the Fire EMS service want to be involved in your community in that? The PPE situation being addressed by Chief Ludwig and Chief Sinclair. How will we make sure that we have appropriate PPE into the fall and available for use in a variety of infectious disease presentations? And then finally, when will the COVID vaccine be available and ready to use in the community? You will very likely be involved in that vaccination process in order that all patient groups, particularly those that are not close to the healthcare system, you may need to be involved as fire EMS leaders in the community. Chief Ludwig, thank you for the opportunity to present. We're in a move ahead, plan ahead mode at this point, and I thank you for the opportunity to participate.
Well, thank you, Jim. And again, we appreciate you serving on the Coronavirus Task Force and just all the wonderful information you provide every week. And I use that word wonderful, not that the coronavirus is wonderful, but that what you're providing to us is invaluable to keep us safe and keep us up to date on the information so that we can make wise decisions out here as leaders. So thank you again so much, Jim. I appreciate it. With that said, I'm now going to turn it over to our Government Affairs Director of the IAFC, which is Ken LaSala. And I think Ken and I have spent more time than I can imagine together on the phone, working the phone, so to speak, with our people in the halls of Congress, trying to see what we can do to get PPE for our people and address many other issues that need to be dealt with at the legislative level, including trying to get funding for the AFG and the SAFER grant. And so I'm very appreciative to Ken and his staff and what they've been doing for our members out there. So Ken, I'm now going to turn it over to you.
Hi, good afternoon, everybody. I just have a couple brief updates I'd like to give on what's going on legislatively. First of all, the Senate continues to work on just kind of regular business, confirming appointees to the Trump administration and judges and things like that. The House is supposed to come back on Friday, and that's when we'll start seeing what this fourth COVID-19, or maybe the fifth COVID-19 response bill actually has in there. So this is really the big week to make the push for Chief Ludwig's signature initiative for $5 billion each for the AFG and $5 billion for the SAFER grant program. So please, if you all could, as Chief Ludwig mentioned earlier, take the time to go over to our Legislative Action Center and submit your comments to Congress. We'd really appreciate it. Moving forward in the Senate, one thing which they are looking at doing, hopefully about taking care of in the next week or so, is legislation to clarify the PSOB eligibility for the families of COVID-19 line of duty deaths. I talked about this legislation last week. Basically, it would grant a, conditional presumptive disability to firefighters, law enforcement, EMS who die in the line of duty during a COVID, as a result of COVID-19. There's really only 3 conditions. The officer has to be engaged in a line of duty action or activity between January 1st, 2020 and December 31st, 2021. The officer has to be diagnosed with COVID-19 or have to submit evidence that they were infected with COVID-19 during the 45-day period beginning on the day of duty of the officer, and that the evidence indicates that the officer had COVID-19 or complications therefrom at the time of the officer's death. So that bill was introduced this week by, or actually last week by Senator Grassley from Iowa. It has 15 co-sponsors, and they're moving quickly to get it through the Senate Judiciary Committee and then hopefully get it onto the Senate floor. Moving on to the next slide, I just wanted to highlight the fact that this week there's some important due dates at the end of the week for some of the AFG and SAFER programs. The COVID-19 AFG grant application period, the deadline is Friday. Chief Augustine, or Dr. Augustine and Chief Ludwig have both talked about getting prepared for the fall. It's important to point out when you, as you're starting to do your planning for the fall, you can actually apply for this AFG grant for funding to be able to start buying personal protective equipment and sanitizing supplies for the fall. So, definitely take a look at applying for these grants. And then also you see there, there's also the Fire Prevention and Safety Grant application period ends on May 29th. Chief Lawrence is going to talk about the HHS payments, so I'm going to turn it over back to Chief Ludwig. I appreciate everybody's time.
Ken, thank you for that update. We sincerely appreciate it. And again, to you and your staff, thank you for all the wonderful work you're doing for our members and for the fire service to deal with issues at the federal level to get the legislative action that we need done there. So again, I just want to reiterate your words that I encourage everyone on this podcast, or this webinar, to go to iafc.org/take-action and send a message to your elected officials in Washington, D.C. Next, we're blessed to have someone who is just a true proponent and represents us at such an outstanding level at the fire service level, at the federal level, I should say, and that is our Administrator, United States Fire Administrator, Chief Keith Bryant. And so we are so blessed to have you, Keith, in that position at such a crucial time in this country right now. So, Keith, I'm now going to turn it over to you, and you will also introduce your 2 guests you have with you. Thank you, Keith.
Thank you, Chief Ludwig, and thanks to everyone that's listening in today. I appreciate you taking the time. We have some, what I believe will be some useful, beneficial information that we are going to pass along to you today, and I'm thankful to the IFC, again, Chief Ludwig and Chief Sinclair, and the opportunity to work with them not only in these webinars, but also as we have representation on the IAFC's COVID Task Force. So we're going to talk about PPE best practices and decontamination today, and I am pleased to have with me today a couple of gentlemen that I know have been doing a lot of great work in this area. Captain Joselito Ignacio. Captain Ignacio is a U.S. Public Health Service Officer currently serving at the Department of Homeland Security and FEMA as the Chemical, Biological, Radiological, Nuclear Science Advisor and Program Manager for the Interagency Modeling and Atmospheric Assessment Center. Mr. John Koerner is a CBRNE Advisor in the Office of Health and Human Services Assistant Secretary for Preparedness and Response for matters related to national medical preparedness and response to CBRNE incidents. In that role, John leads the development of innovative, evidence-based interventions and guidance to support the nation's medical and public health response to catastrophic disasters and terrorist incidents. And we're going to hear from those two here in just a minute, but I did have a little bit of information to pass along to you before we get to them. When it comes to PPE best practices and decontamination, and I know we've put this disclaimer out there before, but as you all are very well aware, a lot of those things, as well as the information and research that's going on right now related to the COVID pandemic is as rapidly changing and evolving. So as far as what we present to you today, we believe that it's current up to about May 7th or the end of last week. So we want to make sure that we keep current and relevant with you in terms of the information that we pass along to you. In terms of what FEMA's involvement has been, obviously, dealing with the largest global medical crisis over the last 100 years has been challenging. We know that you've had those same challenges as well and been resource strapped, and conditions have been challenging for you. But since March, FEMA has facilitated the transfer of over about 86 million N95 respirators, 123 million surgical masks, 8 million face shields, 940 million gloves, and coordinated about 145 supply flights of PPE and other medical equipment from overseas distribution points, which has gotten that here a lot quicker than obviously it would have came by ship. And we continue to work closely with our federal partners to make sure that the distribution of that PPE is based on current projected needs from the information that we have. In addition to that, the Defense Logistics Agency has secured about 60 Battelle decontamination systems for the sanitation of N95 respirators and distributing those again on current projected needs where we believe they're most needed. And finally, FEMA and Health and Human Services have obligated about $62 billion for COVID-19 response-related activities. Now, I say all that, and I want to, I'm not trying to create the impression that everything has gone great or perfect. I think we all know that there's been some issues that went along with the distribution of PPE. Hopefully, that's improving. I think a lot of the improvements that have been made are because of the comments that we've received from the fire service industry, like the IAFC, the IFF, and other groups that we've been in close communication with. And we'll continue to be in communication with all the groups to make sure that if there are hitches and hiccups along the way, that we're doing our part in communicating those up to FEMA leadership. So I give you all that information, and at the same time, my hope is things might be getting, or conditions may be improving in terms of PPE availability and distribution. We've also been working very actively to address the needs of fire and EMS throughout the non-government organizations as well. One thing I wanted to mention to you, as far as information gathering goes, we're doing a special study, if you're not already aware, using INFRS, and to this point have collected information on over 135,000 emergency responses from about 3,200 fire departments out there that is specific to response to COVID-related emergencies. If you're not aware of that information, we post that weekly on our website, so please take a look at that. We have a map that actually shows where those calls are coming from and what numbers. So I think that might be useful information to you. And if you're not participating in that, please take a look at it. And I think, as has been mentioned, the more data that we have about this, the better. So with that, I am now going to turn it over to Mr. John Koerner. John, thank you for being here today.
Thank you so much, sir, and thank you for the kind introduction and the kind words. It's always an honor to speak with this group and any of the membership, and it is truly an honor to be working with you to help provide some advice and guidance in terms of protecting those that are out on the front line every day. Next slide, please. So the real purpose of this discussion is to provide a venue to reflect upon some of the best practices for the preservation of personal protective equipment. It says in healthcare, but we do really mean first response through skilled nursing facilities and everything in between. And I think importantly, as you heard Dr. Augustine mention, that we're talking about PPE in the context of protecting first responders and healthcare workers now, for those hot spots that may be emerging over the summer, and then looking at the future surge operations. Next slide, please. So I want everybody to understand that this wasn't just a government project and some smart people in a room trying to figure out a problem set. When we produced the fact sheet that I'll introduce you in a moment, we did go through a methodology wherein we saw FEMA issuing the FDA issuing these emergency use authorizations. We got real smart on those. Those were followed quickly by the CDC strategies to optimize the supply of PPE. We went through kind of an expanded but expedited literature review to kind of capture best practices. And I think importantly, rather than just reading papers, we reached out and talked to the responders and talked to the providers in the field and the leaders of those responders and providers to find out exactly what is going on. I think that there were 3 weeks there where I spent 2 to 3 hours a day on the phone with colleagues in the field and gathering some of their experiential evidence. We ran the initial drafts of the fact sheet through a focus group of providers, practitioners, and first responders to make sure we were getting it right. And then, of course, the government component is we did have to send it through a pretty intense review process. I think importantly also the data component, we have assembled, going all the way back into March, kind of an ad hoc technical working group to understand better the science behind decontaminating things that are intended to be disposable, and how we might provide some confidence in the users that this processes are okay. They don't destroy the respiratory protection in this case, and that they are protective for the folks out front. Next slide, please. So I think importantly, when we're talking about preservation of personal protective equipment, particularly for this audience, is we're talking about the things that are not intended to be reusable. So we know our turnout gear, and we've got devices and methods to clean those up every day that we use all day and every day. But this is more about preserving those disposable respirators and masks and face shields and eyewear and gowns and gloves that are used on a regular basis. Primarily, our focus is on respiratory protection and masks and on eyewear, but you'll see the concepts that we're discussing really do apply across the board to all PPE, because if you make administrative changes or you make engineering changes to the work environment, you can limit the number of PPE changes that are required, and also you can limit the number of folks that are required to put on PPE. I just drove through Washington, D.C. yesterday afternoon, and I saw 2 engines and an ambulance. Apparently, a woman in an apartment was having an issue. She was ambulatory. They followed some of the guidance that I'm about to show you by bringing her outside to do the assessment. They had a limited number of medics working the assessment piece, and everybody else stayed back until they could make a determination as to whether a transport was required. And that's exactly what we're talking about, rather than sending 7 or 8 people in fully protected. If it's safe to do it in a low volume manner. Next slide, please. So why are we doing this? There is the National Academy of Science and Medicine, Engineering and Medicine, some years ago published the first crisis standards of care documents. This is well thought out. A number of us have been on these committees in terms of how do we transition for whether it's a biological attack or a nuclear attack, in this case a pandemic, how do we transition from the normal way we do business to ways where we can still provide the highest level of care, yet start conserving and adapting to save supplies, to save beds, to save responders. And the contingency standards intended to be applied during periods of expected shortages. The bad news is that I think we are still in a period of expected shortages going through the fall, and I'll tell you why in a moment. But we're still in a period where we need to be considering preserving PPE until we have the entire supply chain and the demand signal wrapped up and we can move forward. The whole idea is to keep us from getting into crisis status and taking those measures that may be extraordinary and certainly wouldn't be used on a normal day. Next slide, please. So with this, what we did is we developed this fact sheet. You see the link at the bottom of the page. The audience will have access to this fact sheet and the slides, so you can go there. But I think you already saw, going back to the beginning of April, the Fire Academy was kind enough to share our reduce, reuse, repurpose mantra, which is indicated by that graphic there. And I know it's on the page at the Academy. Next slide, please. So the idea is really to amplify some of the strategies that some of us are real familiar with now, suggest some appropriate actions based on science and experience. Right now is the time to begin using PPE strategies. Actually, it was a month and a half ago or 2 months ago, and just reflect upon the pillars of practice, and that is to reduce that demand signal, to reuse those things that can be reused in a safe manner, and then to repurpose. And I'll describe what repurpose means, because it's not the traditional way we think of repurpose. Importantly, the caveat I have here, especially now in the next week or 2 weeks, as we start opening up in the United States and other industries are in demand for the same personal protective equipment that we are, it's important to know that even though the supply chain to our first responders and our healthcare facilities is vastly improved over what it was just 2 months ago with respect to PPE, that now we've got the other, I don't even know what percentage of the economy that's coming back online, and many of whom use personal protective equipment, and they've become accustomed to using disposable protective equipment when otherwise, things like elastomeric face pieces were commonly used in practice. Next slide, please. So how do we do it? Everything's based on the hierarchy of controls that we're all familiar with, that you've heard from your safety officers, that quite frankly, the fire service helped to develop. Right now, if you're not a first responder and you're not in a hospital, folks need to be saving their PPE for your use. Maintain that social distancing, and I just described the patient encounter that I observed being conducted outside a moment ago. Next slide, please. So what are we talking about when we're talking about some of these reduction measures and reducing that rate of PPE? You see in that image There's a doctor or a nurse doing a telemedicine consult. This also gets to some of your triage lines that I heard mentioned earlier, where you try to get as much information from that patient as you can that we otherwise would not have collected. Using those barrier controls, doing interviews with cars, windows up, trying to improve your ventilation, limiting visitor access, and just talked about some of the telemedicine and technological solutions. Doing things like moving vents and IV tower or vent poles and IV towers out to the hallway. That same goes with some of the equipment on response. Next slide, please. So what are some of the other work practices that we can talk about? We can minimize the number of people that have contact with a civilian or a patient, work with cohorts of patients or civilians so that you don't, if you've got a whole house full of potentially infected individuals, interview them all in one person, interview them all in one place at one time and get that initial assessment so that you don't have multiple people having to suit up to do that assessment. It might take a little bit longer, but as long as they're competent, it's a good way to limit that burn rate. Consolidating activities to single visits and seeing what you can do to change some of the workflow practices. And then, of course, understanding exactly how much PPE your organization uses. We in times of plenty, we don't necessarily think about those numbers. We think about, there's somebody that orders this stuff. They usually have enough, and it comes in on a regular basis. And you don't really understand that in a time of COVID, when your usage rate is going to increase and the supply is not as available, how much PPE you actually use. And I think that some of the surveys that IAFC and the Fire Academy and some others have done in EMS are really demonstrating that this massive increase in the utilization of PPE, or at least demand for PPE, that needs to be mitigated. And then, there's things like extending use times, and I was just on a call earlier today, and it sounds like most folks are actually extending use times for much of their otherwise disposable PPE. Next slide, please. Some other thoughts about reuse, and Captain Ignacio will speak much more to this in terms of the decontamination of respiratory protection. And I already spoke to some of the optimization of the supply of PPE in terms of extended use and reuse policies, keeping an eye on PPE. I was listening to somebody from Mount Sinai last week, and they had to remove the surgical masks from the ED because they realized that the masks were just disappearing, and they weren't being necessarily used just for the patients coming into the hospital, but they were leaving the hospital as well. And then implement what Lito to Captain Ignacio will get to is implementing guidance for the decontamination and reuse of filtering face piece respirators. Next slide, please. Repurpose, and I think this is important, and it gets to some of the ingenuity that we have seen in the fire service and evidence basis behind trying to solve problems, especially as you heard articulated in times of tight budgets. And some of this has to do with, typically when we say reuse or repurpose rather, we may be talking about taking a type of medication and reusing it in a different way. In this case, we're talking about finding alternative ways or alternative supplies and alternative types of PPE that can provide at least as good a protection as what we're used to. In this case, you see somebody doing a swab. They've got the window up, so you got a barrier in there. But interestingly, they're wearing disposable coveralls. And I did hear that caution about, it is getting to be the warm season, and the last thing we want is a bunch of our folks suffering from heat stress. So strategies where that's appropriate are important. and there's probably some work practices that cause you to not have as much exposure. The supplies, I know that many of your departments and organizations have been receiving donations. That's repurposing. That's an alternative source of respiratory protection. Next slide. So last but not least, we train as we fight. And importantly, if we're going to be providing first responders with alternative PPE or allowing them to use PPE for longer periods of time or reusing and all of these concepts we just discussed, it's important because we've just spent decades drilling everybody on the importance of using the correct personal protective equipment for the correct job and function all the time. So folks need to know that with any of these changes, if you're using elastomeric respirators instead of an N95, they need to know why, one, but also they need to get that extra training that it's required so that they know how to properly use, don, doff, decontaminate that reusable piece of respiratory protection that they may otherwise not be familiar with. So with that, next slide, please. We'll transition over to Captain Ignacio, and he will speak to the reuse component of the reduce, reuse, repurpose, specifically targeting the decontamination of N95 respiratory protection.
Great. Hi, thank you so much. Thanks, John. Thanks, Chief Bryant, for the introduction. So I'm Captain Ignacio. I am the CBRN Science Advisor at FEMA within the Office of Response and Recovery. And you've probably been hearing a lot about this idea of decontamination and reuse of disposable N95 respirators given the current crisis shortage that the nation is facing. So reuse is simply just that best practice that John alluded to or described in detail as part of this broad strategy of preservation of PPE. This really began within the Supply Chain Task Force and moved over to the Healthcare Resilience Task Force within FEMA when the National Emergency Declaration was declared for COVID-19, because we realized early on that the PPE demand will greatly exceed the amount of supplies that can come in to support healthcare professionals as well as the first responders. So with regards to crisis capacity, when you look at the language in the CDC as well as the Food and Drug Administration's emergency use authorization, we only talk about N95 decontamination and reuse when the nation or the healthcare facility starts to experience that crisis shortage of PPE. Typically, these N95s, as John has described, is a one-time single-use capability. But given that the supplies of new respirators, disposable respirators, is a challenge, CDC and FDA recognized that there needed to be authorized ways of decontaminating these N95 respirators. So where does this come from? What's the science behind it? So in the CDC guidance that's cited below, there have been, the CDC looked at peer-reviewed literature on what has been done to validate the efficacy of decontaminating N95s. The ones that seem to be most promising are the ones that are on your slide. The vaporous hydrogen peroxide, or VHP, moist heat, and the ultraviolet germicidal irradiation, I should say irradiation. So let's start with the VHP. This is going to be the most common, and right now, as I'll describe in the later slide, the VHP, vaporous hydrogen peroxide, go back one. Right now is the one method that has received FDA emergency use authorization. It has been shown in the literature to have an antimicrobial efficacy of greater than 99.99%. At the same time, the filtration performance and the material degradation seems fairly insignificant, but up to about approximately 30 cycles in the literature, or in the case of 1, up to 20 treatments of decontamination with vaporous hydrogen peroxide. Moist heat was also found to be effective, also showing fit performance to have been fairly preserved. But what they did find in some of the respirators when they used moist heat was that there was some seal compromise found in some of the respirators. And then with ultraviolet germicidal irradiation, they did find, again, very effective efficacy in terms of antimicrobial kills and a 90 to 100% passing rate after 3 cycles. But what they found, which makes sense because you're essentially heating the material, is that you're starting to see some material durability reductions at higher doses of ultraviolet irradiation. So here are some of the treatment levels that were found in the literature. They did use Geobacillus spores as well as some bacteriophages as the microbe tested, and that's where they found the antimicrobial efficacy. Battelle did a study using the biocoil Claris hydrogen peroxide vapor, where they allowed a 10-minute conditioning and then 20-minute gassing phase, 150 minutes dwell time, where they allowed that gassing phase to remain on the respirator, and then 300 minutes of aeration. And then there was also another study involving the Claris VHP. And then ultraviolet germicidal, they actually used it against influenza A, avian flu, or avian influenza A, H5N1, and MERS and SARS-CoV coronavirus, and found a very good antimicrobial efficacy. But again, we talk about the material degradation. There were also some other studies done using microwave generated steam or microwave steam bags. You probably have seen these in food product stores. They did seem to find, according to the literature against bacteriophage and H1N1 influenza, 99.9% kill. I didn't have, however, any information on the respiratory integrity after using those methods. And then finally, the moist heat incubation was found as effective. What has not been evaluated, which you might have heard a lot about, is the liquid hydrogen peroxide and the ethylene oxide. Those have not really been evaluated. There is a move by one company to use ethylene oxide as a method for N95 decontamination and reuse. That has not yet passed or been issued emergency use authorization yet from the FDA. So these are the systems to date that have received a emergency use authorization for N95 decontamination: the Sterilucent, the Steris B Pro, ASP Sterad, and the Sterizone, and then the large Battelle critical care decon systems. The Sterilucent, the Steris, the ASP Sterad, and the Sterizone are commonly found already in many healthcare facilities because they already are authorized to sterilize certain medical equipment like endoscopes. They've just now been extended that authorization for use for N95. The big difference between those 4 systems in the slide and the critical care decon system is really about volume and the number of times you can decontaminate an N95 respirator. So these hospital sterilizers, you can only decontaminate an N95 respirator either 2 times or 10 times. And if you notice, the volumes that you can insert into these systems are fairly limited. While the Battelle critical care decon system, they have an FDA EUA that allows an N95 respirator to be decontaminated up to 20 times. And there's a process for documenting how many times a respirator has gone through those cycles. But you could also do it by volume. Each decontamination chamber, which you see here, which is a 20-foot shipping Connex container with a vaporous hydrogen peroxide generator attached, they basically can accommodate up to 10,000 N95 respirators at one time. So let me speak really quickly about the Battelle critical care decon system, because this is the system that the Department of Health and Human Services has funded through the Defense Logistics Agency for use at the state, tribal, territorial level if they submit a resource request form. So these systems, if they are in your locality, the way to get to use this system is to sign up on this website, on the Battelle website. And then after that facility, whether it's an EMS agency or a healthcare facility gets enrolled, they'll be assigned a site code, and there'll be instructions on the Battelle site in terms of how you document on each N95 respirator that site code. Many healthcare facilities have found that also placing the name of the person who wore that N95 respirator helped in increasing usage, because many healthcare professionals liked having their respirators returned back to them that they used rather than someone else's. And then there are instructions on how each of those organizations are supposed to collect and bag the N95 respirators, properly package them, and then send them to the nearest CCDS site. And then it's just like an off-site dry cleaning service. The Battelle staff will pick them up, or will receive those packages, and decontaminate them, and then schedule a time for pickup by that healthcare facility or EMS agency. This process, like I said, is contracted in full by the Department of Health and Human Services. There is no cost incurred by the state, tribal, territory, and for users, there is no cost in using the system itself. So with regards to preservation, I want to reiterate what John described. It's really a reminder about a hierarchy of controls, and there are ways to do that. And John gave a really good example of that, what he saw this past weekend. And there are authorized through FDA capability to decontaminate N95 respirators for safe reuse. And this is a time of crisis right now with the challenges that we're seeing with supply to meeting demand for N95 respirators. Anyway, I want to thank everyone for the opportunity to speak with you this afternoon.
All righty. Keith, any closing comments at all?
Just to thank again Mr. Koerner and Captain Ignacio for their time and being with us today and the information that they provided. And again, Chief Ludwig, thank you and the IAFC for allowing us to continue to partner with you as we try and work with you and the fire service through this crisis. Just to remind everybody, this information, you can go to our website. You'll be able to see it there, as well as a lot of other information that we put on there and continually update. Ken LaSala mentioned the AFG and SAFER grant period ending this week, the May 15th. So just wanted to throw that reminder out there. I checked last week with the grants office, and believe it or not, there weren't just a lot of applications so far for that AFG supplemental under the CARES Act. So I'm sure that there are more now. But if people haven't done that, they really need to do that. And take advantage of that funding as we work to see what additional funding may come available in the future. With that, thank you everyone out there for the great work that you're doing, not only in your response and the care that you're providing, but the level of reassurance that you're providing the communities that you work in. Thank you, Chief.
Chief Bryant, thank you. And I just reiterate, we are so blessed to have you as our United States Fire Administrator during this crucial time. We couldn't ask for a better advocate. Your leadership has been exemplary during all this. And I want to thank not only you, but also all of the staff at the United States Fire Administration, all they're doing. And I want to also thank the guests that you brought on here today and all the wonderful information they provided to our listeners. So thank you, Chief Bryant. I really appreciate it. With that said, next is our guest speaker will be Chief Pete Lawrence from California. And Pete's going to talk about the CARES Act, the Provider Relief Fund, and how that's impacting and some of the issues that are surrounding that with the HHS and reimbursement and how that funding can benefit your department. So, Pete, you and I have known each other for over 20 years, and we're blessed to have you on here with your knowledge base. And so I'm going to give you the floor, and you can share your pearls of wisdom with us.
Well, thank you very much, Chief. And again, I've been working with the IAFC for several decades on reimbursement issues, and I think the leadership provided by Chief Ludwig and the IAFC staff is absolutely exceptional, and it allows us to get a lot of things solved for the fire service. So, next slide. Reimbursement, ambulance reimbursement, it's as complex as the tax code, and the CARES Act is really no different. We did get a bunch of money for health care. It's $100 billion for public health and social service emergency funds. There's a lot of information or dollars for Medicare providers and suppliers. And again, we have to always remember there's a difference, providers being hospital-based and suppliers being field-based, like ambulance companies and fire service. There's 3 primary funding opportunities for our agencies: the round 1 allocation, which has already been done and was automatic; the round 2, which you have to apply for; and then some uninsured claims processes. So next slide. Round 1 allocation was taken care of in mid-April, and that was a direct payment of a little shy of 6.2% of your fee-for-service receipts. So from 2019, when you were getting paid by a Medicare fee-for-service, the administrative contractor, they took 6.2% of that and gave it to you as a fire agency. If it was a private ambulance company, if you have a contract, for example, a pass-through agreement, out here in California, LA County, Orange County are 2 primary examples of that, where the private ambulance company bills on behalf of the fire service for the ALS component. In that case, the private ambulance company did get 6.2% of that ALS add-on. And so I highly encourage, and as part of one of the blog posts put that in, highly encourage agencies who do these pass-through agreements with private ambulance companies to work with them, because they got money based on the ability to bill at the ALS level. So the payment that came in was automatic, and it was not based on your national provider identification number. It was on your taxpayer identification number. So for many cases, like in my case, my city, it went directly into our normal reimbursement account. It did not come into the fire department's account. So if you didn't see it, especially if you're a fire district or something, check with whoever your overall statutory agency is you work under. They may have the money, but I'm pretty sure everybody by now has got that figured out. Next slide. Round 2 funding is not automatic. It's a little less than the last round. It's only $20 billion. And you have to apply. And there have been some issues with the application. Most of it's relating to account numbers. So you have to go online. You have to sign up, attest to some conditions that we'll talk about here in just a moment, and provide some financial information, and then also identify what your 2018 fee-for-service reimbursements were. And again, it's not the Medicare Part C, the managed care. It's just the Part B Medicare direct fee payments that you receive through the MAC. And so the information on where to go for more information is on the slide. Next one. So the round 1 and 2 terms and conditions, and this tends to be what Evan Davis and myself and Chief McAvoy, who've been working on this, and they've done a wonderful job providing oversight and leadership here, is what's really causing a lot of the concern and consternation. None of us are concerned that we're a supplier in good standing. Some of the questions come down to what can the funds be used for? And then there's some general statements HHS has made that have made it very confusing for people as to whether it's a good idea to even accept them. So the bottom line is these funds can be used to prevent, prepare for, and respond to COVID-19. And this is where some of the confusion has come in, because HHS, Health and Human Services, stated that they consider all patients to be possible COVID patients. And so that started getting people concerned about the balance billing aspect. In actuality, what HHS was saying is that if you provide service to patients, you are considered to be preventing, preparing for, and responding to COVID-19, because we don't know which patients truly have it. So that's where some confusion came down to, and we'll talk about the balance billing component. But they can also cover lost revenues attributable to coronavirus, and that could be for those of us here, necessarily on the West Coast that aren't in the high impact. My county's got 3,000 or 4,000 cases, I believe now, but our call volume is down. We got people who don't want to go to the hospital. And if we have good numbers that show what our trends and transports were and how much we lose per transport, so make sure you know your revenue per transport, the CARES Act funding can be used to cover those expenses. So you cannot offset expenses that you're going to get through either a public assistance grant or through an AFG grant. You can't double dip. So you need to make sure that you are keeping accurate records of what you're being reimbursed and what invoices are covering, which equipment, supplies, or services are being covered. So you've got a wide area of how you can apply those round 1 and 2 funds to your city, to the fire department for this. And I don't believe that there's anybody who accepts the money that's not going to have an expense that is going to be covered here. When you get to the limitation on out-of-pocket expenses, it specifically is relating to balance billing in-network versus out-of-network. And it says the recipient can't collect from the patient out-of-pocket expenses in an amount greater than what the patient would have otherwise paid if it was an in-network claim. So again, when you look at what a presumptive case of COVID-19 is, HHS has finally described it as a presumptive case of COVID-19 is a case where a patient's medical record documentation supports a diagnosis of COVID-19, even if the patient does not have a positive in vitro diagnostic test result in his or her medical record. So what Evan Davis and Chief McAvoy and I have been working on is getting HHS to give us some specific ICD codes, the International Classification of Disease codes, where we know that if it's an influenza-like illness case, that's probably be considered a presumptive, especially this time of year. So if we're transporting somebody with respiratory issues, we're transporting somebody with fever, those patients, we're going to have to make sure we accept only what we would accept had it been an in-network claim. As such, go to the next slide. The limitation does not ban balance billing, and some people are saying it has to accept, you have to accept whatever the insurance company provides. That is not the case. If you get those influenza-like illness codes, and there's again some specific codes we're working on getting HHS to identify, your billing agency, when those codes are being submitted, when the claim comes back from your insurance, if it's Medicare or Medicaid, you probably that's it you're going to get plus the 20% copay. You still can collect copays. We don't balance bill the Medicare patients. For your insurance, it's contingent upon asking the patient or the insurance provider what that individual's current insurance policy covers. If it says that they have a $250 copay for an emergency ambulance ride, then that's what they have to pay. It is a problem where ambulance is normally not considered in-network. Most insurance companies don't accept it. We're trying to deal with that legislatively. I know here in California specifically, but it's not. This is not a ban on balance billing, and you can continue to collect copays, and you can continue to collect the amount that the person's insurance policy says you can get. And again, I think all of your funding that you're going to get is not going to be more than what you are expending. So next slide. Finally, the HRSA, or Health Resources and Services Administration, has an uninsured patient fund, and this is going to be ongoing. And they're going to provide $10 billion worth of coverage for patients that you've transported who have these presumptive COVID, so again, influenza-like illness codes or documentation, and they're going to start accepting claims. This last week they did. You got to go in and submit your claims for each individual claim through their portal, and you have the ability to have your ambulance billing company, if you don't do your own billing, your ambulance billing company is able to do this automatically as part of their billing process. So if they get a patient with no insurance information, they run them through Medicare, they run them through Medi-Cal or Medicaid, and they do not have coverage, they can submit these patients who have this influenza-like illness symptoms and documentation to this fund, to the portal, and get reimbursed. And it'll be paying at the Medicare rate for your area. So the key, and Chief McAvoy from the EMS section says this on a routine basis, is documentation, 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 documentation. You have to make sure your staff is documenting exactly what it is they're encountering, and make sure that it is able to document and support the influenza-like illness. In those cases, we then know that we need to deal with only getting the portion that is the in-network amount from a insured patient, and we also know that the billing company can bill the portal for the uninsured amount. So there's a lot of money that is available to support fire departments. Is it enough? No. You know, the conversation or the comments that Chief Ludwig made earlier about impact to cities and losses, until they provide funding directly to cities, counties, states, fire agencies, it's going to be more that we're going to lose from the COVID than we're going to gain from all of these offsets. But again, this chips away at the loss and allows you to keep going. Again, ambulance billing is very complex. There's a lot of rules. The IAFC is continuing to stay on top of it, and we do have a letter going forward from Evan Davis, who's the strategic manager for government relations and doing an excellent job for the EMS section. And we hope to be able to provide more information as we go. So that's it for me.
Well, thank you, Keith. I'm sorry, Keith. Pete, I'm sorry. And we really appreciate the valuable information you provided today. As we transgress into this economic abyss that we're going to be falling into, it's so important that fire departments make sure they're tapping every dollar that they can on what they're reimbursable for or what they're entitled to under the CARES Act. So again, your information today, Pete, was just spot on, and we appreciate it. So I want to thank all the panelists today, including our guest speakers, United States Fire Administrator Keith Bryant, his guests from the federal government, and Chief Pete Lawrence. They all provided terrific and outstanding information. I also want to thank Chief Sinclair and Chief Pegram, who are chairing our different task forces for me. And finally, I want to thank our CEO, interim CEO, Rob Brown, and the members of the IFC staff, who I know are working long hours and weekends. For those who are listening today, if you have any questions, please email COVID-19TF@ifc.org. I'll say that again, it's COVID-19 COVID19TF@IAFC.org if you have any questions. As a reminder, we will be doing these webinars every Monday at 4 p.m. Eastern Standard Time, and we will also include information in the future on mental health and behavioral health, resiliency, economic, a variety of different topics based upon whatever that we can push out to you that is valuable for you to know. Please go to IAFC.org to register for future webinars. I am honored to serve as president of this esteemed association and also in this noble profession with so many outstanding people who make a difference in their communities every day. Please join us on our webinar next week as we provide the latest updates and vital information. In the meantime, everyone, please stay safe. God bless you, and may God bless the United States of America.